Hello and welcome everybody to today's Curiosity webinar brought to you by Qure.ai and Hardian Health. And today, on Valentine's Day, we are talking about heart failure, broken hearts on Valentine's Day. I hope no one in our audience at home or at work is suffering from a broken heart. But if you are, you've come to the right place. We have two of the world's leading heart failure experts, plus Professor David Lowe from Scotland, who's an emergency physician, and I myself am Dr. Hugh Harvey, a radiologist from the UK and health technology consultant. Today's webinar will be about an hour and a half maximum in length, and we're going to be talking today about all things heart failure, including where does AI fit into the care pathways potentially. But before we start discussing the meat of the matter, we are going to meet our panelists. We're going to start with Giuseppe Galati. He's from Italy. He's based in Milan. Giuseppe, do you want to introduce yourself to our audience? Tell them who you are, what you do, and why heart failure is so important to you.
Giuseppe Galati, consultant cardiologist in heart failure and cardiomyopathies, based in Milan, Italy, and I am interested and performing this job already for 10 years. I have been grow up in the advanced heart failure and heart transplantation unit, and after I managed two center, heart failure center in Italy, one in top hospital. For me, heart failure is a mission because, as you know, it's becoming the leading cardiovascular disease, not only in prevalence and incidence, because of the aging, because of ischemic heart disease became more treatable, and so doesn't the mortality of myocardial infarction across over the last 20 years has largely reduced, whereas heart failure now affect more than 65 million people across the globe, and this the leading cause of hospitalization in Western world. And also you see there are evidence now on the last statistic that also the leading cause in cardiovascular disease, if you do correctly, you see your count, because the incidence is growing very fast. So fast that before the pandemic of 2020, just some weeks before, it was, you see, defined the epidemic of the third millennium. After, you see, there was the COVID-19, so this, you see, name has been removed. But this, I decided to dedicate myself because the most of heart failure is can be preventable and treatable, and also from the other side because the main research in cardiovascular, the cardiovascular area, the cardiometabolic area, from 2011 up to now, so over the last 10 years, the heart of the research is heart failure. We discovered much more things over the last 10 years in this area than over the previous 30 years. So if you think to the fourth pillar of FRF, they completely changed in 6-7 years, completely. Two pillars, they are completely new. If you compare just up to 2013. So to be very short, it is a very, you see, innovative and fast growing area, and this challenging because it's a major problem of all the healthcare system and across the globe for all the patient life. You consider that 1 in 5 patients, of 5 people, they will develop heart failure in their life. So it's very common.
So it really is, as you say, an epidemic of this millennium. 65 million people worldwide, 1 in 5 people potentially will develop heart failure. So I can see why someone like you yourself would dedicate your life to it. We have another cardiologist on the call with us today, Dr. Jaime Hernandez, based in Texas. Jaime, could you spend 2 minutes introducing yourselves to our audience. Explain who you are and why heart failure is so important to you.
Hello, thank you for having me here. My name is Jaime Hernandez. I'm an advanced heart failure and transplant cardiologist. And I lead the program at Baylor Scott & White Health for Central Texas and the greater Austin regions. For us, being a large hospital system, heart failure is one of the most important priorities. Not only as we know and was eloquently explained, is a frequent and one of the most frequent causes of hospitalizations, readmissions, emergency department visits. But it's also a disease that it's chronic, that impacts longitudinal well-being, and that it drives strong resources when patients get really sick. And as we think about heart failure as a continuum, we need to find ways to innovate. We need to find ways to anticipate disease states in which we have to, deploy heavy, intensive care resources like temporary mechanical support, like ECMO. And always when that happens, that's what I usually do in the hospital, take care of patients that are really, really sick. One of the questions that I have is, how did we got here, and what could have been done differently to change the trajectory of these patients, to modify the trajectory of these patients towards an outpatient setting, and have a controlled progression towards their next step, whether that's medical therapy, whether that's device therapy, or whether that's that replacement therapy. But also there's, now that we have so many new medications and devices and interventions, always thinking about whether if I have got early this patient or at their time zero, whatever that means at the moment, whether we could have done an impact towards remission or recovery of that heart function. So, that is what keeps me sort of going. That's what keeps me awake at night, trying to find pathways to anticipate going from these very late stages of disease, which are easily to identify because they're so sick, and making that exercise of knowing how did they got to that point, and if we could do something different as a system and as a society and as a medical community, global medical community, to anticipate those issues.
So it really is a preventable and treatable disease for the vast majority of patients. And as both Giuseppe and Jaime have said, there's a need to catch it early. There's a need to anticipate who's going to deteriorate before we get into that heavy intervention. David, you're Professor of Emergency Medicine based in Scotland. You're at the sharp end of the Scottish NHS. Tell us a little bit about yourself and where you fit into the heart failure pathway.
Thank you very much. So I'm David Lowe. I'm a consultant in emergency medicine, but otherwise I essentially hold the West of Scotland Clinical Lead job for innovation. I'm also the Clinical Director for Innovation for Scottish Government, with my academic interest focused around about AI and clinical decision support, specifically in long-term conditions. And there's, as you've described, a number of drivers around about that, not least around about reducing hospitalizations, length of stay for those patients coming into my emergency department, and indeed emergency departments across healthcare systems worldwide. Heart failure is a particular challenge both in the west of Scotland, Scotland and the UK, for which at the moment 80% of people get their diagnosis of heart failure during their index hospitalizations. That means that they're not getting that diagnosis before they come in, they're actually getting it at the point where they present with undifferentiated breathlessness, and usually will have a protracted length of stay where they get access to BNP biomarkers as well as an echo for definitive testing. So my interest and the interest of our group is around about really looking at that critical pathway to diagnosis and treatment initiation and guideline-based therapy delivery, and being able to streamline those processes, recognising there's some critical rate-limited steps for which that early detection piece is absolutely critical to doing that. And ultimately, I suppose what we see in emergency departments, in GP surgeries and primary care, is there's a lack of heart failure awareness. Symptoms are fairly non-specific. It's people presenting with shortness of breath or inability to complete their daily tasks. And how do we focus that initial question of a patient coming and saying, I don't feel quite right, I feel more short of breath, to be able to streamline the diagnosis of heart failure, to be able to initiate them in therapies, because we know that at the point of initiation of therapy, we can reduce heart failure hospitalizations within a month. We've got really good evidence around about that. So lack of heart failure awareness, how do we optimize early detection? That's going to be the purpose of this discussion today. Timely access to diagnostics, and that's some of the work we're doing around about AI echo. And then finally, how do you optimize access to heart failure specialist care, potentially using digital platforms, and be able to bring that all in together into a cohesive service model that patients can engage with, benefit, that sees a reduction in hospitalizations, ED attendances, and all the benefits of not having ambulances stacked outside the hospital. But then thinking about that patient experience, and when we talk to any patient, what they'll say is, we don't want to come into hospital. Anything you can do, leveraging our data to support that diagnostic state early, we'll happily engage in, because it's important for us in terms of reducing morbidity and mortality. That's more than enough of an introduction for me. Thank you.
It really is interesting. And what I want to do now is take a small step back for our audience who might not all be clinically trained, or at least not cardiology trained. Giuseppe, I was hoping you could give us a brief overview of the main causes and symptoms of heart failure, and what are the initial standard diagnostic tests that are done.
Yes, of course. As you well know, heart failure is a complex syndrome that over the last decades received many physiopathological definitions. The most famous is from Eugene Brown in the 80s, that defined him, you see, as a pump failure, mainly, in which the heart, this is the failure of the heart in pumping the blood that is not enough to match the metabolical needs of the body. But sooner, very sooner, you see, also this, you see, wonderful physiopathological definition, you see, of Eugene Brown meets the limits, because it didn't meet, for example, the heart failure with preserved ejection fraction, no? That for many decades, you see, has denied the existence. It was called, I remember the wonderful editorial of the European Journal of Heart Failure 20 years ago, the dress of the king. That was wonderful. No, but the heart failure with normal ejection fraction is, you see, an abnormalities of, you see, the diastolic function of heart failure. That, you see, it reduce, you see, that increase the pressure, and it creates the congestion. So also from the physiological point of view, they have to integrate this in the physiopathological definition. But to be, you see, more practical, we have a clinical definition that was made recently by the universal definition of heart failure, that define as a complex syndrome characterized by typical signs and or symptoms. You can have one or both, you see, and that is confirmed by an objective measurement of congestion that can be elevated level of NT or B and natriuretic peptides, or congestion detected by, for example, imaging method like chest X-ray, echocardiography, or by hemodynamical, you see, pressure, increase of pressure at the right heart catheterization that can be, you see, at rest or during exercise. This is for satisfied some special definition, for example, from the European Society of Cardiology of heart failure with preserved ejection fraction. As previously Prof. Lowe told, unfortunately, the symptoms of heart failure can be not specific, and also the signs, they can overlap with other different pathology. So in some special scenarios, they can be challenging for, you see, a general practitioner, for not a specialist, to think and diagnose heart failure. The most frequent symptoms, there is the short of breathness, fatigue, reduction of tolerance to the exercise, and weakness also. But these symptoms, for example, some of them, also some cough, they can be also similar, for example, if you think also to COVID-19, to be just, to talk something that is very recent and common. Also, some signs can overlap, with other situations like pleural effusion, ascites, and so on. The etiologies that they can cause heart failure, they can be multiple, because, as I just told, heart failure is not a disease, it's a syndrome, and this the most it is the consequence, it is the end of a large multitude of cardiovascular disease. To be short, for heart failure with reduced ejection fraction, the most over the last 40 decades was ischemic heart disease that now is reducing, and cardiomyopathies, they are rising. And we have dilated cardiomyopathies, for example, that genetically driven. We can have hypertrophic cardiomyopathy, that this can cause HFpEF or heart failure with mildly reduced ejection fraction. When you have the bar out evolution of hypertrophic cardiomyopathies, we can have amyloidosis and restrictive cardiomyopathies, and we can have arrhythmogenic cardiomyopathy or some strange cardiomyopathy like Takotsubo. Okay, after we have congenital heart disease, myocarditis, pericarditis, and to be, too complex, this to make this scenario more complex, there are not only the cardiovascular disease, there are the interaction with several systemic disease. Diabetes, chronic kidney disease, there is 40% of they coexist, chronic kidney disease with heart failure, cardiorenal syndrome. Obesity, very common in America, for example, obesity like a cause, arrhythmias, and many situations, dysfunction of thyroid, also during the pregnancy. There are several conditions that they can cause heart failure. So heart failure is very common. And to be short, to answer your question, when it starts heart failure, this can impressively increase your mortality and reduce your quality of life. So it has a severe impact in prognosis and in your life. The tools for the diagnosis, there are, the first tool is the mind of the doctor to have a high level of suspicion of heart failure that is very common. So think to heart failure. This is the first tool. The second tool, very, very common, very easy to do, is a biomarker like Prof. Love told. NT-proBNP, BNP, it's very easy for you. Also, the general practitioner, they can do this. And after you have, for example, chest X-ray and echocardiography. In many situations, echocardiography requires specialists. So you have to call for your calling cardiologist. If you are not a specialist, please do me the echo. But this can be, if you are in the hospital, it can need some times, depending on the setting. If you are on the, the territory, the chronic, this can take days or weeks. So there is a time for this, okay? Chest X-ray, it's an intermediate, test between biomarker and echo, because it is not so fast like NT-proBNP, but it can, require less days of, the echo, and this varies fast. So you can have this both on the territory, but basically is more used in the hospital setting. So to be very short, these are the very, very basic, tests that you can do when you have the suspicion of heart failure. After, if you want, we can talk something more detailed.
That was a really beautiful and detailed description of heart failure, and I wish I'd been taught it in such a passionate way when I was at medical school. Almost makes me want to become a heart failure specialist all over again. Jaime, I'm going to move to you. We touched on some of the causes, and it's quite evident from what Giuseppe said that it's not one disease, it's a syndrome, it's linked to multiple other comorbidities. One he mentioned was obesity. You're in America, in Texas, which I understand. Correct me if I'm wrong. Texas is the most obese state in America, or one of the most obese states. And another thing that Giuseppe mentioned is that we're seeing ischemic heart disease, which I assume will be related to smoking, is decreasing. So are those trends true in what you're seeing in Texas? And then my follow-on question is, once we've got a diagnosis or a working diagnosis of heart failure, what are those heavy interventions that you mentioned in your first answer? How serious does it get for patients in the worst cases?
Yeah, no, it's a hard act to follow after Giuseppe's explanation, which was wonderful. And I think here in Texas, yes, we have a metabolic disease pandemic as well. It is connected and reflected to the high morbidity and mortality that the COVID-19 unsurfaced for places in which you have that combination of low vaccination rates and high metabolic disease. And I think connected to a pandemic and sort of lessons learned is that these patients do have, in the vast majority, a tendency to have heart failure just based or precipitated predominantly by obesity, hypertension, diabetes, in which all in combination sometimes leads to ischemic heart disease, but also leads to what we call diastolic heart failure or heart failure with preserved ejection fraction, which is a different type of heart failure as the one that is associated with reduced ejection fraction or a dilated or big heart, but still has the same sort of common funnel pathway of congestion or refractory congestion that will end up affecting lungs, liver, kidney, and be translated with frequent hospitalizations. And once your organs get congested, the tendency for infection is much higher. So all these sort of mixed diseases that you see in the obese population, in which you'll see multiple diagnoses at the same time, heart failure with preserved ejection fraction, pneumonia, reactive airway disease, hypoventilation. So all those things are connected, and really one of the aspects that we are really trying to work upon is, of course, in the prevention of heart failure by preventing and anticipating, metabolic diseases, really targeting that population. I will say that is just one piece of the puzzle. I think there is a strong interest and in reversing at least patients that are already obese and preventing obesity. But there's another component of heart failure. These patients that truly have heart failure with reduced ejection fraction, that really don't have obesity or metabolic disorders, but that really present 1 or 2 or 3 times in the hospital. And other than just trying to get rid of fluid from the lungs with decongestion, there's no more profiling beyond just an ultrasound of the heart. So to Giuseppe's point, in trying to understand the reason behind heart failure, ischemic or non-ischemic, it's very important that we really endorse the concept of sort of deep phenoprofiling to understand why this is happening. And the most common cause sort of link to obesity and metabolic disorders, diabetes particularly, is ischemic heart disease. So access to an evaluation for that, like coronary angiography, and risk stratification as well with other non-invasive testing, becomes really important once you have an index admission. For us, again, we really advocate and the index admission to be the golden opportunity to try to profile risk, to exclude coronary disease, and to really start, if coronary disease is not the case, really start sort of untangle this very, complicated and heavy spiral of heterogeneity in which we classify all these non-ischemic causes that can be from genetics related to infections in the past, or inflammation related to autoimmune disorders, or disorders that are associated with substitution of the normal myocardial cells with fibrosis, protein, or other types of entities. So again, we have a lot of tools now to try to best understand the type of heart failure that we're dealing with. I think it's just more of an issue with access and getting these patients to a place in which they can be profiled and somebody can direct from, just like an orchestra, the whole interdisciplinary team to try to find the reason behind it. There are some patients, and that is in the ideal world, in which patients can go to the clinic, to the cardiomyopathy clinic, and be in a situation in which you can discuss their findings and by step trying to figure it out with different diagnostics or interventions. There is another cohort of patients in which they will transition from being in the hospital with decompensated heart failure to being extremely sick, meaning that their perfusion to their body organs, brain, liver, lungs, kidney, is not adequate, and that the patient requires interventions like IV medications, mechanical ventilation, renal replacement therapies to try to stabilize that end organ dysfunction. In addition, and in many cases, also the need for these more heavy interventions that we were mentioning before, like temporary mechanical support, in which you have to use temporary pumps to help the heart provide, circulation to all these other end organs. So again, patients with heart failure can get to this point of cardiogenic shock or a disease state in which the end organs are failing. And in that context, we still don't know that transition from decompensated heart failure to really bad cardiogenic shock. But what we know is that it can happen all of a sudden in de novo patients. It can happen on patients that have a persistent diagnosis of heart failure. And if it happens that in that context of admission or hospitalization, they develop in-hospital cardiac arrest, their mortality can go from 50 to 70% in the hospital. So I think that if you see it from a public health perspective, from even from a health economics perspective, we're really doing things backwards, because we try to react upon these very advanced disease states in which you already have congested organs, and try to reverse that with machines that are very costly, with machines that, yes, can help us save these patients' lives, that transition to, so you can transition to recovery or to heart replacement. But again, I think one of the things that innovation might help us elucidate at some point is, where is that time zero starts? And when they have the disease, when or how are these patients are going to progress, so we can anticipate. And again, I think that is truly the future of heart failure, trying to anticipate the end stages or heavy resource states.
So I want to pick up on a couple of things that you mentioned. You said that the index visit, so the first time someone presents to hospital, is really the golden opportunity to spot these early signs of heart failure. And I think that's absolutely right. And I'm going to ask David to expand on that in a minute. And the other thing you said is, obviously we're doing things backwards. We are treating people once they get to these pre-morbid states of heart failure, when they are not perfusing their organs correctly, that when the body is flooding itself with fluid, they're congested. And surely the value proposition here is in more primary prevention and earlier diagnosis, which I guess is the reason why we have David on the panel, because he's the guy who will spot it when they come into A&E. David, do you echo what the others have said in terms of this golden opportunity to spot it and diagnose it? And the follow-on question is, how are you spotting it and diagnosing it, given your limited couple of hours with a patient?
Not often a limited couple of hours at the moment, unfortunately, due to flow. Okay, so I think there's a couple of points. I think Yemi's absolutely right around about that cardiometabolic renal syndrome that we're increasingly seeing in Texas, west of Scotland, in fact, worldwide, and how do we respond to each of those groups? So some work that we're doing, for instance, did a large multinational study looking at high-risk individuals with diabetes, recognising a diabetic clinic, if you actually screen those individuals for heart failure, unsurprisingly a high percentage of them do have it. But as Jamie said, we're doing it backwards. We're looking for a group who've already got established disease that are coming into a diabetic clinic rather than proactively looking for them. So I think there's two answers to your question. There's one almost at policy and strategy level for our healthcare system about using structured data, and this is where AI is very good because it's heterogeneous, to do case finding in the community for those at highest risk of the condition. And that again is based upon your economic service appetite for that threshold you set for how many patients you're prepared to bring into a diagnostic clinic. We can touch on that later. But if you're going to go out and find those individuals, how do you bring them into a streamlined process to diagnose them? For which chest X-ray is one of those key components. So there's lots of patients will have a chest X-ray done on their first index presentation with chest pain. So it's a screening tool. So we do 110,000 X-rays in my hospital alone during the course of a year. And using that, and as Jamie's saying, aligned with other structured data points to support case finding in the community. Now, what that does do is then split you out into potentially two requirements, either proactive case finding, bringing people in, or secondly, as Giuseppe's already said, using the doctor's brain and using clinical decision support. We saw a lot of that work during COVID of using chest X-rays, a screening tool, to potentially identify patients that have heart failure and asking that question of the clinician, saying, probability of heart failure in this patient is X. Should you therefore do a BNP to therefore further consolidate, increase the vector towards a diagnosis of heart failure, plus or minus then an echo, depending on the availability of your healthcare system. So I think we've got those three opportunities: proactive case finding in the community using structured data, index contact points to gather structured data of which chest X-ray biomarkers, clinical history, held in a structured way, not a handwritten note, to support that deep phenotyping or characterization of individuals that allows us to follow their time course and then consolidate some of the work we're doing around about AI, case finding. And then that third piece around about those high-risk individuals, given healthcare systems across the world are already challenged, to be able to, let's go to the diabetic population that we're bringing in and actually do a BNP in those individuals, plus or minus an echo, because that's a group that probably do, depending on the prevalence of disease in your individual healthcare system, have heart failure or have sufficient prevalence that it's both clinically and cost effective to proactively screen for those individuals. So I think it's recognising there's a continuum. We're not at the point that everybody that has got nascent heart failure has a diagnosis already. So therefore, depending on the drivers in your healthcare system, do you go and find out as many people as you possibly can? Versus, do you go for those highest risk of hospitalizations and drivers of future costs and start there? And I think that's really where the question lies. In terms of the emergency department context, it's patients are coming in with undifferentiated, as Giuseppe says, breathlessness or other features, potentially of heart failure as part of the differential. And it's how do you gather structured data to support that? So some really great work being done by Professor Nick Mills, who's one of the British Heart Foundation professors across in Edinburgh, using an AI solution called Qure.ai to support who should get a BNP done within the emergency department setting. And that's really just about supporting clinicians that are often challenged, 2 o'clock in the morning, 200 patients in the department, wherever you are, to be able to say, this person, the rate limiting or the step you can do to add the most value, incremental benefit, is to think about a diagnosis of heart failure, and therefore, here's the next thing you do. And chest X-ray is a key point in that. You've got undifferentiated breathlessness, especially in this post-COVID or peri-COVID world, of being able to differentiate who should get what next test to accelerate their ultimately initiation of therapy, diagnosis, and future treatment plan.
Interesting. So chest X-ray is coming up a lot as one of these early diagnostic tests at the point of care. And yeah, about 95% of people with any chest symptoms would get a chest X-ray in the emergency department, if not up to 100%. So Giuseppe, for the benefit of our audience, when a patient has a chest x-ray taken in the emergency department, or maybe as an outpatient, are we good at picking up heart failure or the signs of heart failure on chest x-rays? Or is it sort of a forgotten diagnosis that people tend not to think about? What's your opinion?
If you follow it now the line of David and Don Jane, we have two great things. The first, to improve and raise the diagnosis and raise the awareness, because probably everywhere in the Western world, in the emergency department, heart failure is always present every day of the year. Now they have probably in every hospital, huge hospital, there are more heart failure than myocardial infarction. 20 years ago, it was the opposite. There is a flip, okay? So there is a huge need to raise the awareness. And from the other side, to link with the previous talk of James, in the history of heart failure patient, you see there are many crossroads, how much they have a long history of heart failure, 10 years, 15 years, but they don't know. Nobody told them that they had heart failure, so it is underreported, underdiagnosed, and undertreated. So in the end, you go to the department of James and you got an ECMO, an impella, and heart transplantation, or you see a left ventricular assist device, and this is if you are lucky, because as you know, there is a shortage of heart transplantation, you see over the last 20 years, and also, as you know, the left ventricular assist device, they are very expensive. So this is main characteristics of Western Europe and United States, but other countries have less access. So if you are not so lucky, you go in palliative care and death. Okay, so we have these two things. How we can raise awareness, the diagnosis, and how we can see that this is underreported and underdiagnosis. Because in several cases, you see that there is someone that makes a chest X-ray, and there is someone that makes the furosemide or diuretics, but they don't report in the main diagnosis. They don't tell the patient that they have heart failure. They don't inform the patient about the risk of mortality. Okay, so now the key for the diagnosis, it's related always to that universal definition of heart failure, that you want the symptoms, you want the sign. But there is a wonderful editorial coming from the country of Prof. Love, that is Scotland, from John Cleland, that tell us that the key is congestion, because congestion in heart failure develop much before than symptoms and signs. When you have the signs of the symptoms, you have already 10 liters more in your intravascular, you see, volume and extravascular. Read this wonderful editorial of 1.5 years ago. And so there are many tools now for detecting congestion. You have impedantiometry that we use, for example, total body. There are, you see, impedance of the ICD that is quite old, not so recent, and there are new systems coming from the military that is radio frequency of the lung. But there is, like the electrocardiogram, an old and new method that is called chest X-ray. Typically, chest X-ray you can find historically go to look for cardiomegaly, you see for bilateral pleural effusion, for the redistribution of the blood, you see there is the interstitial and vessel, we say picture in the lung that is, increased, the hilar congestion, several signs, no? But we have to say that there is, in the third millennium, with the large, excitement and plethora of new techniques, EMR, CT, scintigraphy, PET, the new horizon of imaging, speckle tracking in echo, whatever you want. The old method, sometimes, you give less attention. So the new way is, for example, to take something that is very simple, like Prof. Lowe told before, that you, for example, in hospital is very easy because everybody they got an X-ray. Very often, it's the rule. and you apply, you see something that is systematical, organized, that you see automatically collect 1, 2, 3, 4, 5, and this you see help very much. You see that the radiologist, because he pushed the button and he received an algorithm that say, oh, be careful here, you see, and this grab the attention. You have a red box. This is high risk for heart failure. Maybe have another second, another look, because this can change the diagnosis. So applying new method that they can change this in hospital, for example, this change, you see the history of your patient, because you can start very easily also in the emergency department new therapy, like the SGLT2 inhibitors, the MRA, they are very easy to start also there, even easier than beta blockers of ARNI, for example, because they are tolerated also in the patient of Jane, that they are hemodynamically, for example, compromised, you see, or they have some other organ dysfunction. SGLT2 and MRA, they are very well tolerated, okay? And you change the diagnosis. But we have, you see, as we told, a large spectrum. We don't have only the hospitalized patient. Remember also to the large plethora of patients that they are on the, you see, in the territory. Also applying this method, you see, when you see general practitioner or someone, your cardiologist, your interventional cardiologist have this, you see, he asks the chest X-ray. Applying, you see, this algorithm of artificial intelligence can raise, you see, the awareness about heart failure. So it's something, in my view, that also this is the reason, because I am participant, as you know, you see, I'm very passionate about this. We have to find new way how to, you see, removing the captains and put this on the spotlight to see, okay, there is congestion, there is heart failure. To be very short, 15 years ago, it was the same for rare disease. You see, when you got, you see, there are thousands of manuscripts. Amyloidosis, it's a rare disease. It's always, each manuscript, it starts with this, you see, it's a rare disease, okay? But now, after 15 years that we have several tools, you see, now we are discovering that amyloidosis, it's not a rare disease. It was just an underdiagnosed disease, and many of that patients, they received the diagnosis of hypertension. As Jane told, several times in their life, 10, 15, they had the crossroad. You have hypertension, and after you die. Okay, instead they had amyloidosis. Okay, but this was not diagnosed. This is the same for heart failure. Or you have ischemic heart disease, you have angina, you have myocardial infarction. Okay, and you can see this in the history of the patient. This is heart failure for 15 years. This man, he's taking furosemide for, and he never started the GDMT. You can find very often some low dose of beta blocker and an ACE inhibitor. And just this, you see, for 15 years. And after it came you with 15% of ejection fraction, 25 of hospitalization over the last 10 years, and you have to call Jane, okay, let's screen him for some advanced program, because it's already, you see, you do the CMR and everybody's fibrosis, you see, okay, let's see what we can do. So this is something that can change the history of millions of patients across the globe.
Jamie, I was smiling along with that, and I think you were smiling along with that as well. That's a common thing that you see, people who've had this undiagnosed but chronic heart failure for a while, being mislabeled perhaps as hypertension or ischemic heart disease, and then they end up at your door, nearing ECMO or maybe transplantation if they can find a donor. So I want to get back to the central core of what this webinar is about. And Jamie, maybe you can speak to this. I find it beautiful and poetic that we have a technology which is now 100 years old, the chest X-ray, and we're now able, with modern technology, to repurpose it to be able to give us more information than we ever knew was available on it, by having this decision support AI added to a chest X-ray report to say, this patient has some radiological signs of heart failure. Does that make you excited? Do you see immense value in this? And is this something that you think is going to change and tip the balance in favor of these patients with early stage heart failure?
Yeah, I mean, the main value that I see on anticipating disease is that you create access at a stage in which perhaps you might have the greatest impact on the available therapies that we have. Available therapies that have been tested on patients with advanced disease already, that they had to have a diagnosis in order to be on the trial, in order to have access to a trial. They will have had already some degree of perhaps fibrosis in their hearts, and their recoverability much lower than a patient that has been just diagnosed. I think that's the beauty behind it, in the sense that you can create a big impact by routing that patient, instead of going from an emergency department visit for asthma, then to a primary care doctor for asthma, then to a lung doctor for asthma, and then, ends up intubated on multiple pressors, and they're calling for ECMO because he's actually, somebody did a pro-BNP is very elevated, and an echo, the heart is not moving. I think, the impact that you can make on that disease trajectory is very valuable. I don't know if Giuseppe has had these cases, but, I think we all have at least 10 plus cases in which they have been misdiagnosed with lung or reactive airway disease, particularly in young patients, particularly in athletes that have a lot of reserve, a lot of muscle reserve to perhaps compensate. Those are really sad stories, because they seek access to care. They were provided some degree of workup in which there was some suggestion that they had the heart as a problem. And as it was said before, it's very unfair at times for the emergency medicine physicians that are seeing, 100 patients on a shift to be accurate on every single case. And at some point, you cannot send, cardiac biomarkers in every single patient that rolls into the door. From an economical perspective, that is, I think, unsustainable. A lot of emergency rooms in large hospital systems that have been exposed to these situations have just said, you know what, I'm just going to send shotgun approaches. And then you think about, if we are able to anticipate all these, CT angiographies and other very high cost imaging tests, for an early ultrasound of the heart, from an early consultation with a cardiologist, and understanding that the pathway is heart failure, I think that creates a big impact. And it's hard to quantify until you have the data and longitudinally analyze all these aspects. But so I think that's that anticipation. The other part is that there are specific disease entities that I get very worried about, and they're of course flagged not only by the systems here, but also across the world, which is, for example, peripartum cardiomyopathy. And peripartum cardiomyopathy, again, there's always concerns about not knowing, or in the risk stratification of these patients, not knowing that they have a cardiomyopathy until after pregnancy, or during pregnancy, or the end part of their pregnancy. And I think for example, this will be a wonderful way of anticipating this problem when they have had a chest rate before, or for whatever reason, a respiratory problem during their pregnancy. Anticipate that this was the issue. And again, that cohort, it's a patient population that we care for a lot, because for both ways they're stigmatized in the sense that they cannot get imaging early, and at the other end, if they don't recover their heart function, then they cannot get pregnant again. So if you can anticipate disease early, recover these hearts in on young patients, they can actually perhaps change the disease trajectory, and they can live normal lives.
There really is an opportunity here to get in there earlier and to find these patients super early on, as long as they've had the chest x-ray. So I was going to move on now to how do we deploy this in the real world, and what does a good deployment and integration look like? I'm going to go to David on this because I think you're the closest that I know of to deploying AI in the real world setting. So you can speak openly and plainly. Has it been a simple journey? What are the difficulties? And what's the ultimate sort of end goal?
Yeah, thank you, Hugh. That's a really good question. So I suppose the complexity is how do you, as Giuseppe's already said, transform what is essentially an old organisation and add a new technology. But actually, as Giuseppe said, we've got an old technology that we're actually augmenting with a new technology into an existing expensive old organisation, to steal the HIMSS phrase. I think the challenge is around about stakeholder management and understanding how to deploy, recognising there's a number of stakeholders, the cardiologists, emergency physicians, there's a radiology team, there's the PACS, Chris, technical teams as well, and then there's clearly the wider board level operational piece around about demonstrating value when we've got constrained funding for being able to deploy these things and be able to demonstrate that providing an augmented decision support tool, which is essentially what this is, can add value both in terms of the clinical care that patient's receiving right there and then, but equally what does that do to long-term costs, reduction in hospitalisation, improved outcomes, and being able to describe that. So ultimately, being engaged in this process is around about robustly evaluating it and recognising you need to respond to every stakeholder's requirements, its cost effectiveness, its clinical effectiveness, its clinical engagement, its patient PPI engagement across that process as well, and be able to describe and essentially deliver an evaluation in line with deployment of these technologies, recognising that there are some centres, Glasgow, that are very prepared to take on the challenges of those things and potentially are the vanguard for then supporting other centres that are perhaps not as large, but don't have the same quantity of imaging or the same burning platform challenges in terms of unmet needs for the population. I think for the purposes of this conversation, we're really talking about augmented insight. So it's whether or not you deploy that at the front door for the clinician that's acquiring an image, and what do they do about it, which the pushback from ED clinicians will often be, that means it's another set of things I've got to do. I mean, it now says this person's got heart failure, I've got to do a BNP, etc., etc. That's another blood test that I've got to go back to the patient, I've got to explain this, and that feels like additive steps. So we've got to be able to describe what that value looks like for the hospital system. If you deploy it after the fact, so then you're going to have to be able to phone back those patients or contact them and say, actually, when you're in, your X-ray had evidence of heart failure, we want to bring you back. So that is an additional cost. That's bringing people back to a new clinic to be able to do these tests, recognising the false positive rate of chest X-rays to be able to do that. And it's understanding, again, the implications of that process. And if you take this out with the heart failure context and look at lung cancer, for instance, then you're potentially phoning back some patients saying, actually, we think you've got lung cancer, or you've got an image that's suggestive of that, and will the patient be comfortable with that, or the doctor missed that finding, and you've got to explain that. And that, again, becomes a really challenging conversation, especially if you think about progression of lung cancer, as it is with heart failure, but it's perhaps a little bit more challenging, is that your mortality increased by 10% every 6 months. You don't have a diagnosis of lung cancer. So there's those implications, because you're not just often deploying a heart failure solution, you're deploying a chest X-ray solution that will have a number of pieces to it: heart failure detection, COPD detection, lung cancer detection, that sits within it. So again, it's understanding the use case, how it's going to be deployed, how you describe its value to all those stakeholders. And again, recognising that if you do deploy it, if you take the data back out the back end, is the potential to improve the performance of it. And that's certainly the approach that we're taking in Glasgow with a number of different conditions, is to do an ensemble-based AI technique of taking the probability of there being features suggestive of heart failure, i.e. increased cardiac exacerbations, or big heart, or pleural effusion, so fluid at the base of the lungs, and adding that to structured data, similar to what Jamie was describing, and saying you've got a probability from structured electronic health record data, you've got a probability that's been returned by the chest X-ray solution, that detects that, and adding those two elements together to boost the performance, probability, positive predictive value of returning patients actually do have heart failure, do have COPD. And again, recognising that in the Glasgow population, 20% of patients who have heart failure also have COPD. So what we did with another project previously is we brought a whole bunch of 853 patients through a rapid early diagnostic pathway. But unsurprisingly, we generated more work for the respiratory clinicians as well. Because yes, absolutely, but half of that population has heart failure. There's another 20% that were unknown to a respiratory clinician that suddenly there's 200 new patients into their early diagnostic COPD clinic. So there's now probably a quite established workaround of being able to think through the implications, both intended and unintended consequences of deploying an AI solution that actually affects other clinical systems, not just we're going to surface an AI prediction of heart failure to a clinician in the emergency department who's going to have to go and explain heart failure in a BNP, but what does that do to the wider system, both in terms of cost, improved patient clinical outcomes, reduced hospitalizations, as well as the resource limitations that might come downstream, as Jamie and Giuseppe have said around about access to echo, and recognising these basic tests, echo, ECG, chest x-ray, then often at the start of a funnel of increasing number of testing requirements to characterise, to understand etiologies, amyloids, what is ischemic heart disease in the driver of that presentation. And I think finally the point was made by Jamie is really important, that there's some really simple steps of being able to say, here's a bunch of patients over the age of 40 with a history of ischemic heart disease or hypertension. How many of them are on furosemide? How many of them have had a chest x-ray? Run those chest x-rays through the AI solution to specifically answer the question of heart failure, to again improve the performance of detection. And that's another potential use case delivery mechanism of the solution that takes out of a very business as usual clinic, primary care, secondary care environment, but actually say, here's a targeted response to being able to improve performance of case finding in the community using either clever AI ensemble-based techniques or relatively simple rule-based pieces of over the age of 40, a number of cardiometabolic renal conditions, plus presence of a chest x-ray in the last 3 to 5 years to be able to do that. And I think that's an important piece, is be able to understand where your clinical hospital system is in the continuum of where do you place that AI that's going to add the most value now, recognise there being a journey to full integration probably in the next 3 to 5 years.
Yeah, I think it's very important to remember that while we are very excited about the performance of detecting heart failure, and I put a link in the chat to a recent paper that shows that this kind of technology can find 86% of patients with heart failure on the chest x-ray. That's fantastic kind of performance. But you're right, David, it's not just heart failure that is going to be picked up by these AI systems. They're going to be looking for the lung cancers, the nodules, the rib fractures, the pneumothoraces, the misplaced ET tubes. There's going to be a whole wealth of information and data coming from these early diagnostic tests, and not just chest x-ray, from all sorts of other imaging, perhaps even blood tests, ECGs, and things like that. So I want to sort of think now futuristically. Giuseppe, let's put our future thinking hats on. In 20 years' time, once AI is everywhere within the hospital, do you think we're going to, again, flip our care model to be moving away from treating diseases to preventing the severity of diseases, using all of these technologies in combination?
I think you are completely right, because I have to say that also I read this manuscript this morning, published last year, like an abstract at the American College of Cardiology. I think the first name is Selick, Art in Heart Failure, and it's impressive. Because I understand David, because from his point of view, you see, this is more, you see, how to say, job-minded. You see, from his perspective, he wants, you see, some method that, like, for example, chest X-ray that help him to find lung cancer, you see, COPD, heart failure, and so on. But to me, what is more interesting is not only, you see, the chest X-ray in itself, but what is, you see, the new horizon. It's the use and the application of the AI, you see, artificial intelligence, to different tools. So, for example, this can have, you see, the revolution for chest X-ray, but you see, we have to start artificial intelligence. Maybe it will be, but I don't know if it will be, can start to do like the human mind, because you see, we have basically three types of, you see, reaching the diagnosis, like the inductive reason. So you, from the details, you reach a final diagnosis. The deductive way of reason, like in philosophy. And after, there is another type that one of my mentors that passed away taught me when I was the resident, is the abduction, you see, abduction way of thinking, that is the pattern recognition. So what does it mean? That you have to achieve a diagnosis, and you have several tools. In this, you see, circle, you see the very expensive coronary angiography or fluorodeoxyglucose PET can have the same value of the electrocardiogram of the chest X-ray for reaching the final diagnosis. So if artificial intelligence can start to do, also, I trust more in human, but they surprise every day to do the same way that how it functions the human mind, to put together the piece of the puzzle. For what I'm telling, to be more practical, that, for example, applying artificial intelligence, so this wonderful job that they did in heart failure, this technology. For example, you can implicate it with the bioimpedance. You say, why? Because, for example, chest X-ray has also the limits, because as Prof. Lowe told you, you can have some signs that they can be also common to some other disease, and also sometimes artificial intelligence can go in the traps when it go also the radiologist's mind. Sometimes this can happen in the differential diagnosis. And then can be also, because heart failure is, you see, subtle, is very, you see, complex, people that they don't have, you see, any signs of congestion in the lungs, but they have in the periphery, you see. So if you apply, for example, the bioimpedance, which is very short, you have to apply two parts, one in the hand, one in the same leg, or in the same, you see, half of the body. And you push this button, you see, and gives you, you see, if there is congestion, euvolemic, or dehydration, and implicate this result together with chest X-ray. Or this can do, you see, for example, chest X-rays together with echo. You see, when artificial intelligence can put together in the future, in the horizon, this result, this can really be a multiplier of diagnostic potential, because it's not only based on only one diagnostic tool. So, skipping from, you see, the treatment of disease like heart failure that has mortality like cancer, you see, there is a wonderful always job that I cite from Mamas et al. From Scotland, you see, cohort of more than 50,000 patients followed for 10 years. The mortality of heart failure is the same of the most, you see, solid cancer. Only the lung cancer perform more badly than heart failure. As survival. It's published 5 or 6 years ago in 2016 or 17 in European Journal of Heart Failure. So this is a dream, because as you know, the American Society, the American Heart Association, and the American College of Cardiology, they put this in the spectrum of heart failure, because this is the continuum from prevention. They put this, many thought, okay, this was not proper when they did 20 years ago. In reality, it's proper, because it explains you that heart failure doesn't start usually this way, you see, from suddenly, okay, you can have a genetically driven disease, it's okay, but for the most, you see, it's something that you can prevent. There are several risk factors, for example, that they can be changeable, like, you see, diabetes, smoke, alcohol consumption, your lifestyle, and so on and so on. And the future, this is for healthcare system to push in prevention. But as you know, you see, this need, you see, the effort of the healthcare system of organization, campaign of awareness like this week for the Heart Failure Week, investment in diagnosis, because there is a problem of access to the cure. European system, they are very, very different from American system, and there is a problem of access to the cure. So I don't know if in 20 years we will, skip from treating all these deadly disease or badly impacting on quality of life or prevention. This is our target, but we can achieve, I think, only with the diagnostic method of an artificial intelligence. This is, a problem of organization of the health system. We need universal, healthcare system in which every people, the rich and the poor, they can have a fast access to the diagnosis, and after, so they can have an access to the treatment. Otherwise, like we are seeing, in the Western world and also for heart failure, the failure of the system, it results that you have always an emergency. So people that they work in the emergency department, they are really aware about this, because the people that they are not treated for months or years from the system, they access at Saturday night or Sunday night at 2 a.m. in pulmonary edema. And this is already a failure, because they can be treatable. So things, for example, to the emergency of hypertensive emergency hypertension, and when you have 200 of blood pressure, they can, just make the blood pressure measurement and start a pill from the general physician, but they start there for weeks, and after you go there, in a life-threatening situation. No, so if you ask me for the horizon, I have a lot of trust in artificial intelligence, more than only in one tool, that this can multiply our solution and our diagnosis. But from treating the disease and preventing everything, I will be more cautious, because I know human, and I know, politics is something that is very slow, difficult to change, especially here in Europe, and this and also this change of mentality of the people for going to prevention, because there are people that they go very easily. I'm sick, and the people that they don't want never to see a doctor in their life, even if when they are dying. So it's something that is very difficult to think now. I am optimistic. The people that they know me, they are optimistic, but it's difficult. But I have a lot of, of trust in this new perspective that give us, the application of AI in cardiovascular disease and in general in medicine.
Thank you. And Giuseppe, it's always such a blessing to hear you talk. You're so passionate. And it reminded me of something you said yesterday, that you used to give your phone number out to all your patients so they could call you at 2 a.m. on a Saturday. And hopefully we can stop that happening. Jamie, do you share Giuseppe's positivity and optimism? And what do you think that the future horizon looks in this sort of combination of AI tools that we're going to see arriving over the next few decades?
I think the focus should be with the problems that we have right now. I think the future is tremendous for it, as well as the responsibility that we have for the best use. And I like a lot what it was mentioned about preventing this disease severity. And I think we have a lot of people with disease right now that will progress towards heart failure, and that's where the true sort of tsunami of heart failure is not coming; it's already here. So I will also be cautious in saying this is just sort of an universal sort of approach that will prevent, like, for example, vaccines from a disease. That's not going to happen, at least in the beginning. But at the problem that we have, the problem that will be something that we can move the needle upon in our lifetime is on these patients that already have disease or they have unrecognized disease, and identifying these early, putting them on the right pathway for access to cardiovascular or specialists with focus on heart failure, so they can be an optimal medical therapy, an optimal device therapy if needed, and then again halt progression, improve the possibility of recovery or remission. I think that's a true challenge, and whether health systems can integrate their technology with their existing medical records to these sort of enhancing pathways that are right now. I think we are still in the sort of dark ages of how we have made best use of our electronic medical records or our medical records in itself to create those pathways. And right now it's still, patients or diagnoses need to be made or referrals need to be made by somebody else that has true certainty that the patient has heart failure in order to see a heart failure specialist. And again, I can see the future being emergency medicine, cardiomegaly. If the patient is stable, they don't have to be admitted. They don't have to have a shotgun approach, but they can perhaps have an access to a heart failure clinic within a certain amount of time. And then the conversation starts in which, again, from time zero, a clinic or a group of individuals that care for this disease specifically are going to have a very different approach as to these sort of like these different providers trying to, not aggressively treat heart failure or just focus on decongestion or just focus on low doses of medications instead of ramping up to the optimal dosages. And I think that's where I feel for us it will create a big impact, making that transition from emergency room to access, from primary care to access, and maybe even sort of consumer-wise, now that they have a lot of these patients on our system access to their own medical records through MyChart, through the phone, trying to understand what that means, okay? So if we even just tell them what cardiomegaly as a finding means, the next step that they will do is perhaps look for heart failure. And then the next step will say, do you have a heart failure specialist? And I think that conversation is another parallel pathway in which you transform or reverse the dogma of physicians telling patients what to do, and then patients actually taking ownership and being empowered by knowledge, so they can really be proactive with their care. So multiple dimensions, but I'm more cautious in the sense that I think caring for the disease states that we have to prevent heart failure or to prevent severity of heart failure is perhaps the best use of this technology.
Yeah, and I think it's right to be optimistic but cautious. I think that is the right approach with any new technology. We are moving towards the end of our session today. So if you are watching in the audience and you've got any burning questions, feel free to type them in the chat and we will try and address them. But before we get to a question and answer session, I'm just going to pose my last question or two to the group. David, it is your turn. What evidence do we need to see? And so you mentioned previously in one of your answers there are multiple stakeholders involved, from radiology departments, the emergency physicians, the operational institute of the hospital itself. What evidence do they need to see in order to be convinced, as we are as a group here, that this is a valuable technology which can help save patient lives? And how happy are you with the progress at the pace of that evidence? And you can be honest on that.
Yes, I think the first thing to say is really challenging to respond to the needs of all those stakeholders. And I'm very mindful of the conversation I often have with cardiologists, and forgive me for the two that are in the room, that they say, well, unless I can see an RCT, I don't care. And clearly an RCT of AI technologies is both expensive, and there's a requirement to be able to demonstrate the technical performance based upon the prevalence of disease and other features of the technology deployed. And how cost effective is that? And that's, as you know, one of the key barriers for technology partners is the cost of doing it. They've got the cost of regulatory approval, they've got the cost of developing their technology, they've got the cost to get to market. And then they've got the cost of evidence generation, the response to all those requirements. And cardiologists especially are a tough crowd to be able to provide sufficient evidence to. But I think that really ultimately cores down to be able to demonstrate improved patient outcomes. And that's ultimately about the robustness of the evidence that requires clinical academics. I'm giving myself a job for the next 5 to 10 years of producing protocols that deliver this into clinical healthcare systems. And one of the challenges that we have is how do we implement at scale, not just do a beautiful study with 400 patients and do a retrospective technical performance is often the mainstay of what these, but actually deploy into large-scale healthcare systems, get over the barriers around about acceptability, usability, and actually have established deployed technology that we're starting to, again, gather evidence, demonstrate clinical effectiveness, cost effectiveness, patient and clinician engagement, and how it fits in with their workflow. And that's often a challenge for the technology companies, is how does this fit in with clinical workflows? You're not stepping out of your established clinical system to do another thing, because that ultimately drops engagement. And then finally, that piece around about sustained use that actually, again, demonstrates both patient and clinical centred outcomes. And that's where it's often really challenging, because this is ultimately augmented insight. And hopefully, after a number of years of doing this, a well-calibrated version of me at 2 o'clock in the afternoon in the emergency department looking for patients in heart failure after giving this talk looks very different than a stressed out junior doctor at 2 o'clock in the morning managing a 40 patient load. And therefore we have to be pragmatic about the studies we deploy, recognising those cost and evidence requirements about being able to demonstrate that this actually works in usual care. And the vagaries that come with a different healthcare system. So you've got 3 people on this call that work in very different healthcare systems, and therefore the drivers for adoption, engagement look different as well. So therefore, going back to your question, the evidence requirements need to be calibrated for the decision makers are ultimately going to buy this technology and deploy it. But equally, you need to have stakeholders that are enthusiastic about wanting it, that actually build the business case to be able to go to the board, to go to government and say, why don't we have AI chest x-ray deployed as a screening tool for every chest x-ray that happens in Scotland or in Italy or in the US, because it describes these value statements. And that's, I think, where we have to get to is, and again, we've talked about this before, Hugh, around about the multiplicity of requirements. It's not just about heart failure, it's about other long-term condition detection and screening, and how that builds into a platform-based approach of how does this technology fit into a clinical work stream that demonstrates value.
Yeah, and evidence just takes time. That's just the nature of the beast, isn't it? But I think we're getting there slowly and surely, and I think it's through people that are on this call and the like, who are pioneering and piloting and trying these technologies out and helping the vendors gather that level of evidence is the only way forward, to my mind at least. We have a few questions that have come in from the audience, so I shall read them out. I think, Giuseppe, if you could answer this one from Dr. Critical, who is a regular viewer of these Curiosity webinar sessions. Dr. Critical says, early detection would mean more load on cardiologists. While AI will aid radiologists, it will increase the burden on cardiologists. How do we tackle
the question is
that problem?
interesting,
So,
but
Giuseppe.
I think the perspective is wrong in this sense that the real problem of heart failure across the Europe, but I am seeing also recently in the US, because before I was thinking that they were better organized, but I see the result of their registry. They are similar to the European registry. is that outside from the heart transplantation and advanced heart failure center, that they are few by nature because they provide expensive treatment that you see each country has to limit and count because no country has endless money or endless reserves. There is, you see, no pushing from the cardiovascular society on heart failure specialists and on heart failure specialization in cardiologists, because if you think the most cardiovascular specialization, they are invasive cardiologists, so interventional cardiologists and electrophysiologists. These are very typical. And after, in the 90s, we have the imaging specialists. The problem that only recently, over the last 15-20 years, the ESC and also American provided a specific field for heart failure, clinician certification, master, pathway, etc., like me. Before the heart failure specialists, they were much few. And if you see the registry, the CHAMP registry and many others, even more than half of heart failure patients across the Western world, they are treated from interventional cardiologists. So the real problem is that our society, and also if you see also there is a colleague that works in the US, that they have also a crisis in the subscription of residents in advanced heart failure program in the US. Okay, so the problem is that we need specific career, specific pathway for engaging heart failure specialists, and we need the houses, how I call the home of heart failure. The problem, for example, in Italy, we made a registry with the Italian Society of Hospital Cardiologists. Before and after the economical crisis in Italy, there was a drop in the, you see, of more or less 40%, 50% of heart failure centers, okay? And after the pandemic, there was another drop of this. If you go region by region in Italy, for example, for talking of the local, you see, but I see also in a very rich country like Germany, for example, many heart failure, you see, management is the, you see, them delegated to the general practitioner. This is okay up to a point. You should create a collaboration and the home for heart failure. So the problem is not the ping pong between radiologists and cardiologists. They are here to work together for the patient. The problem is to create the system. European Union, European countries, but also your American country, they should, you see, increase the number of heart failure, you see, centers, so that you see people that they know where to go, because we have also this problem that in some places of Italy, of Europe, they don't know where to go, because going for a general cardiologist is not the same for going to a specialist in the area. So if you're lucky, you find someone that is expert in the field. If you're not lucky, you will find someone that doesn't, is interested in this. And after, you see, only the center, we have, you see, to build the, you see, career is much more difficult. For example, recently I changed my hospital. You see, it's much more difficult for an heart failure specialist to have, you see, an established and, you see, very calm pathway of career in the field. Whereas if you choose another, you see, field of the cardiovascular disease, interventional, even also preventive, you see, it's very easy, you see, for them, and so they are motivated. So you have to be very sure to increase the center, to increase the people, and to increase, you see, the organization of healthcare system. So if you increase the diagnosis, the problem is not who manage, the problem is the access to the cure and the cure, and the patient, they call in the right place at the right time. This is the problem. So it's not, and also remember about the cost. You think that, you see, this can be just a little more expensive, but think about the heart failure cost. We have a registry in Tuscany, the Arno registry. This Arno is the name of a river in Florence, you see, of more than 45,000 people 5 years ago. Cost related to heart failure hospitalization 5 years ago, 6 years ago in Italy was 1,000 euros per hospitalization. You consider that it means 2 or 3 times they are hospitalized. Okay, and this is without the cost of rehabilitation after the hospitalization. The cost of heart failure treatment impacting 1.5%, you see, of the cost. So the problem is that we diagnose better, we treat better, we reduce the cost, and this is cost effective. Because for a state, it's much more expensive to pay for you for 3 or 4 hospitalization during the year. It's thousands of treatment. Like Jane told you, can you imagine how much cost to put an ECMO, the room, all the stuff, you see, the complication, to put an heart transplantation, or even to put a left ventricular assist device. So little things, they can really do a huge change in our system. But there is we need the political will, and we need someone that organizes well the healthcare system, that we need a unique management. Fortunately, in Europe now we have hundreds of several different management, and within the same country, like Italy, talking about my country, we have 20 different systems because they decided to have 20 different, and they discovered the limit of this organization during the pandemic, when you need a centralized organization for an emergency. So this is not a problem, increasing the diagnosis, but it's the organization after that you should prepare, because otherwise it's not easy to have the argument between the cardiologist and the radiologist who is stronger. This is not, you see, how to deal, to manage the problem when you have, when God gives you a mind to reason.
Brilliant, a very comprehensive answer. So in essence, if we get these AI systems right at this early detection stage, we actually need to increase the number of cardiologists, the specialists we have, but that will be more cost effective because we're not spending the money on the late stage treatments. At least that's the theory, and let's hope we get there. We've got a couple more questions. I'm aware we've only got a few minutes left, so we'll speed through these questions if that's okay. Brody Crichton says that he's seen that there's currently legislation that prevents autonomous AI from being used in the UK. And he wonders whether, firstly, does anyone believe that we should deploy an autonomous AI for, say, evaluating normal scans to free up space in the clinical workflow? And secondly, if you believe this is a good idea, can we see this legislation being changed? I guess I will ask that question. Sorry, I did think I was going to address this to David because this is a UK-focused question. Autonomous AI in 1 minute. What do you think? Good idea, bad? Will the law change?
So I think it's about risk. Ultimately, we've got a risk of chest x-rays that have not been reviewed for 6 to 12 months. Then there becomes the health economic cost aspect of it. If we say that we set a threshold at 99%, then that's 15% of x-rays, which in Glasgow that would be 15,000 x-rays that are potentially normal. You could strip out from reporting. Then if we're sending them to external reporting agencies, that's potentially £5 per x-ray, which takes you up to 75k cost. So therefore, there's very clearly, with the health economic and risk arguing about it when you've got significant backlogs. So therefore, it comes down to risk appetite. I think the CQC will change. It's going to be the threshold that we set, recognising that the performance line, and this is a well-known trope, the requirements for an AI to be performant far exceed the requirements that we currently have for a consultant radiologist. And therefore, again, we need to be cognizant of risk and understand where that risk ultimately sits for a Qure.ai solution as opposed to employed radiologist.
Yeah, I agree. And I would add that we also have to consider the ionizing radiation regulations, which currently tell us that a human must report any episode of ionizing radiation. So that needs to be reworded to say, or equally capable AI, I imagine, in the future. Couple more questions. Nina Fernandez said last time she read the research paper, the accuracy of interpreting chest x-rays regarding congestive cardiac failure was only around 70%. David, this is for you again. How do we make the best use of chest x-ray findings in care delivery? And I guess that question really relies on, is that 70% still the state of the art, and is that good enough?
I think when you look at AUCs for decision support across the board, I think when you're pushing towards an AUC greater than 0.85, certainly up to 0.9, then that's starting to get into both clinically and cost effective, and that's broadly where we are with AI, again, depending on where you set thresholds. I think, as I've said before, that ensemble-based approach of essentially augmenting imaging probability with other structured data. And even if you look at Chris Gale's Find AF paper that was published in the last couple of weeks, that's fairly simple structured data around about the presence or absence of valvular disease, COPD, as the kind of features that were found in that particular model. So it's an understanding of what's an acceptable performance for your healthcare system, how do you set the thresholds, and then whether or not there's a utility in either augmenting it directly with AI using structured data, or are you surfacing that to a clinician to do the decision support element, recognizing cost and resource limitations of all these approaches. And again, that'll be different for different healthcare systems based upon risk appetite, if nothing else.
Yeah, indeed. And then last one, this is not a question, it's more of a statement. Jacob W says that they published at RSNA, which is the radiology conference last year, and they found that doctors can't see most heart conditions on an X-ray, but they can assess size and shape of the heart, as well as fluid backed up in the lungs due to heart failure. And while their chest X-ray and cardiovascular disease risk model might not diagnose specific heart conditions, the researchers do hope that further testing confirms that it can consistently predict a patient's 10-year risk of cardiovascular death. And that just brings us neatly down to why we're all here today as part of Heart Failure Week, and also on Valentine's Day, talking about the heart and everything that can go wrong with it. We've gone 1 minute over time, but thank you so much to our international and esteemed panel.
Thank you.
Galata, fantastic. Thank you very much. Jaime Hernandez, getting up early this morning in Texas, and good luck to you in your clinic in Texas. And Professor David Lowe from Scotland. We have been part of the Curiosity webinar brought to you by Qure.ai and Hardian Health. Stay tuned. There'll be another webinar session next month where we'll focus on a different AI topic. But for now, thank you to our panelists, and thank you very much to all our attendees. Goodbye.
Thank you.
Brilliant. If you can stay online just till it says uploading 100%.
So we don't have to close the window now, and we have to wait the 100%. It's okay? Okay.
Yes. But you can turn your camera off and your microphone off. But thank you so much, guys. I hope you enjoyed it.
Bye, and have a
Thank you. Nice to meet you.
Ciao. Happy Valentine's Day.
Bye.